This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. Welcome to the April Respiratory Care Journal webcast. My name is Shauna Strickland. I am an Associate Executive Director at the AARC. I welcome you to today's presentation, the April Editor's Pick for the Respiratory Care Journal, Contemporary Ventilator Management in Patients with and at Risk for ALI and ARDS. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. Carl Hinkson. Carl is a respiratory therapist, adult critical care specialist, neonatal pediatric specialist, and a fellow of the AARC. He is the interim manager of respiratory care at Harborview Medical Center in Seattle, Washington. Carl discloses that he has no conflicts of interest related to this presentation. Carl, welcome to the presentation.
Thank you, Shauna. I'd like to thank the Respiratory Care Journal and the AARC for allowing me to give the JournalCast for April. This month we are discussing the Editor's Choice article, Contemporary Ventilator Management in Patients with and at Risk for ALI or ARDS. So whenever you start a research study, or before we begin, I should add that the main author on this study is Dr. Stephen Chang, and the study comes from on behalf of the U.S. Critical Illness and Injury Trials Group for the Lung Injury Prevention Study investigators. Whenever you read a research article, the first item that you're going to read is the background, which should ask why did the authors do it. So in the background for this, the patients with ARDS or ALI benefit from low tidal volume ventilation with limitation of plateau pressures. This was the result of the ARDSNet trial that was published in 2000, nearly 13 years ago. Despite several studies, the strategy to best manage PEEP in ALI or ARDS patient remains elusive. It is unclear if there's any benefit to ventilating patients without ALI or ARDS with low tidal volume ventilation. So part of in the last decade, the authors wanted to get a sense of how the ARDSNet trial data has been received amongst academic centers at large. So what is the research question? They wanted to know what variables impact administered tidal volume. They want to know what the impact of ALI and ARDS has on outcomes. Whether or not clinicians are consistently using low tidal volume ventilation after the ARDSNet study has been released. And the authors hypothesized that ventilating with a low tidal volume would be associated with less post-intubation ALI and ARDS. The authors did not for areas of conflict of interest, this research was not directly funded, nor did any of the authors have any direct conflicts of interest. Some of the authors reported receiving research funds or consulting fees, but these were not related to this topic. So how they conducted this study, it was a secondary analysis of the lung injury prevention score study. So this was a study that they had done previously, or was done in tandem with it. It was an observational trial, which means they made no intervention. It was a 22-center cohort study. It was conducted between March and August of 2009. 19 centers prospectively collected data, and 3 centers retrospectively collected data.
So, Carl, this is Shauna. If I could interject a quick question. Of the actual article on page 579, the authors identify that they performed an a priori pre-specified analysis of a 22-center international cohort study of patients at risk for ALI and ARDS. Could you explain a little bit of what that means in English?
I can try. A priori just means planned comparison before data is collected. A priori is a term that comes from philosophy that means knowledge that is innate. And the best way I can describe it is whenever I see it listed in research, I see it as though they kind of made up the information. So they took information that they thought was relevant to the research and then did a analysis of 22 centers that they had international. A cohort study would be a cohort is a group of people with similar characteristics. So they took characteristics of patients along a axis of information that they thought was interested in, and looked at patients for risk of ARDS. For the inclusionary criteria, the patients were included in their research if they were over the age of 18, if they had one or more risk factor for ALI or ARDS, and that was sepsis, shock, pancreatitis, pneumonia, aspiration, if they were a high risk for trauma, or if they had had a high-risk surgery. And these are patients that were admitted through either their emergency department or operating room. Exclusionary criteria, you always want to exclude the patients that are going to bias or confound your results. So they excluded patients if they developed ALI or ARDS within 6 hours of the initial assessment. And the reason that they would do that is because if they're looking at patients that may develop ARDS after being on low tidal volume ventilation, then if they developed ARDS so quickly, that might bias their results. They excluded patients that were transferred from an outside institution because they already may have developed ARDS and may have gone unrecognized, if they died in the ER, if they were admitted for comfort care, if they were readmitted during the study period. And they also did not study patients who never received mechanical ventilation or received mechanical ventilation for less than 1 day. The data they collected was the baseline characteristics, socio-demographics, and comorbidities. They collected the ventilator data that was within the first 6 hours of evaluation, settings, parameters, volumes, and pressures. And for the subjects that developed post-intubation ALI or ARDS, they collected the first set of ventilator data that was after the diagnosis was made. So they collected the ventilator settings in the first 6 hours of admission, and then if the patient developed ARDS later, they collected the first set of ventilator data. The outcomes that they were looking for, the primary outcomes was initial tidal volume and PEEP in patients who never developed ARDS or ALI, and patients intubated because of ALI or ARDS, patients who developed ALI or ARDS after intubation. And it's important to point out that the researchers used the American European Consensus Conference definition because the Berlin definition for ARDS was not yet available. Secondary analysis was whether or not the development of ALI or ARDS happened after initial intubation. And they also looked at hospital outcomes on ventilator-free days or mortality. For statistical analysis, they use the Kolmogorov-Smirnov test for normal distribution, student's t-test or Mann-Whitney for continuous variables. Categorical variables were compared using chi-squared or Fisher's exact test, one-way ANOVA for variation in tidal volume settings. Multivariate analysis was done with logistic regression, one for tidal volume and one for PEEP. And significance, sometimes referred to as alpha, was set at 0.05, and all tests were two-sided. Data was expressed as a median with an interquartile range.
So Carl, this is Shauna again. The authors use a lot of statistical evaluation methods. Why so many? Why was it important to this study to look at the data in so many different ways?
Well, the tests that you use are dictated by the kinds of data that you have. It's important to note that there's 4 categories of data. You have nominal, ordinal, interval, and ratio. And the test that they use depends upon the types of data that they have. So nominal data would be gender, blood type, categorical things. Ordinal is things have rank, but there's no real difference between them. A Likert scale is kind of a common example of an ordinal scale. Interval would be like days on the calendar, and then ratio is sort of the highest level. The first question that they always ask is my data normally distributed? So if what that means is if your data is normally distributed, then you have a normal bell curve. And for higher level data, for like ratio data, if your data is normally distributed, then you can use the student's t-test. If it's not, then you would have to use the Mann-Whitney test. If you don't have interval or ratio level data, then you would have to use a test called chi-squared or Fisher's exact test. So really the type of data and what you're trying to answer dictates the type of statistical test that you're going to do. And since the authors had many different types of data, that meant that they had to use many types of different statistical tests. Also, they expressed data in this research study as median with interquartile range, and that's important because a lot of research studies express the data or describe the data as mean with standard deviation. When you look at measures of central tendency, or if you're trying to describe what the average patient looks like in this situation, you can use average, or in statistics they call it mean. But if your data is skewed, then that mean may not actually describe what your typical patient will look like. In those situations, it's best to use median, which is the centralmost value, and the interquartile ranges. So if I, for example, took respiratory therapist wages and I ordered them from the lowest to the highest, and I averaged them, that would be the mean. Now, if they were normally distributed, then I would know that there would be respiratory therapists who half the respiratory therapists would earn less than the average, and then half the respiratory therapists would earn more than the average. But if I throw a couple of respiratory therapists that are very well paid, that starts to skew the data. And so the mean starts to go towards the higher level, but doesn't actually represent what a typical respiratory therapist would earn. So in those cases, it's best to use a median value. The interquartile ranges means that I've broken the value up into percentages of 1 to 25%, 25 to 50, 50 to 75, and 75 to 100. And the interquartile range is the 25 to 75% range. So it really describes in data that is skewed what the typical data looks like. Moving on to results, this is how the data played out. They started out with nearly 6,000 subjects. They threw out several patients because they had ARDS, ALI on admission. If they were transferred from an outside facility, several for readmissions and palliation. They threw out quite a few, 3,700 with never being intubated. They threw out 1,000 that were intubated for less than 1 day. And that left them with 829 intubated and mechanically ventilated patients. And of that group, 107 were intubated for ALI or ARDS. And the other half, or not half, but the other 722 patients were intubated but did not have ALI or ARDS on intubation. Of that group, 561 never developed ARDS, and then 161 intubated or developed ARDS after intubation. Of the results, this is the baseline characteristics, and this is important because this describes the patient population. Over here is the variables, and we see median age, and it's described as the interquartile range. So we see the median value for the age is 57, and the interquartile range is 43 to 69. There were a lot of male patients. that developed ARDS post-intubation. There were many of them were Caucasian. Many of them had higher Apache scores. Apache score is a measure of illness. Many of them had higher lung injury scores. And there was no real differences in the baseline characteristics in terms of median height, median predicted body weight, median actual body weight, or BMI.
So, Carl, one more question. I hate to keep interrupting, but this table shows us a p-value column all the way to the right there. Could you explain to us the importance of the p-value within the context of this table?
Certainly. P stands for probability, and the way that the p-value was first described to me was it represents the probability that the differences found between your two groups are due to random chance. So if, for example, let's look at male. So there is less than a, that would be described as 0.8% chance that random chance was the reason why there were more males in the post-intubation ALA or ARDS patient. When you're looking at research study and you're looking at the baseline characteristics, what you want to know often or not is they're comparing apples or oranges. If there's a lot of differences between the two groups, meaning that the p-value for several of the measures is less than 0.05, then there's differences between your two groups. In these particular, what we're looking for is because we're trying to describe the data, we're trying to describe the populations, we want to know what the differences are. So we know that for sure that on this particular one here, where the p-value is 0.001, on the Apache score, we know that the patients who developed ARDS post-intubation were sicker than the ones who never developed it or were intubated for it. And then what the term often is used is statistically significant. Continuing on with baseline characteristics, there was a higher percentage of the post-intubation ARDS patients that had aspiration, pneumonia, and sepsis, also shock. And there was also a higher percentage of the post-intubation ALI patients that had traumatic brain injury. And if the p-value is over 0.05, then that doesn't necessarily say that there's no difference, but there's no statistical significance. It may be just random chance for the differences that you found. Moving along, this is the initial ventilator settings and inspiratory pressures. So this would be after they intubated the patients, and within the first 6 hours they collected the first ventilator parameters with the complete set. So looking at it, we saw that there was, for the patients intubated for ALI, no ALI versus ALI, most of them were on volume control. For the median tidal volume, in the no ALI group, the tidal volume was higher. The median tidal volume by predicted body weight was higher in the no ALI group versus the ARDS group, 8.4 versus 9.6. And so you can see the interquartile range is pretty close. So 25 to 75% of the patients, the mid-range, they received a tidal volume size of 7.5 to 9.55 for the non-ARDS patients, and then a little bit lower, 7.14 to 8.94 for the ARDS patients. And here's an interesting tidbit. This is actual body weight. So for the non-ALI patients, the median tidal volume per actual body weight was 6.8, and for the ALI patients it was 6.6. The inspiratory pressures, the peak pressures, there was no difference, but there was a difference in the median plateau pressure. You have, for the non-ARDS patients, they had a lower plateau pressure than the ALI or ARDS patients. And also they had a lower compliance. So this table is a comparison of the patients without ALI, or ARDS at onset of mechanical ventilation, initially treated with a tidal volume of less than 8 versus a tidal volume of greater than 8. So what's interesting here is that if you were a male, there was more likelihood that you got a tidal volume less than 8 mLs. Also, you were more likely to get a smaller tidal volume if you had a higher lung injury score. If you were taller, you got a smaller tidal volume. If your median predicted body weight was higher, then you got a lower tidal volume. And if your BMI was lower, you got a smaller tidal volume. So the larger BMI group got larger tidal volumes, which we'll discuss later. Continuing on, if you had pneumonia, you were more likely to get a tidal volume less than 8 mLs. If you were in shock, you were more likely to get a tidal volume less than 8 mLs. And if you were there for cardiac surgery, you were less likely to get a tidal volume of 8 mLs. Odds ratios. So this is factors associated with greater odds of receiving a tidal volume greater than 8 mLs per kilogram of predicted body weight on initial ventilation in subjects without ALI or ARDS at onset mechanical ventilation. And then they adjusted for the center. When you're looking at odds ratios, the way to describe it, if you're looking at this column here, is that if the value is greater than 1.0 and it's significant over on this side, that would mean increased risk. If it's less than 1.0 and it's significant, that would mean decreased risk. So this was, were they at risk for receiving a tidal volume greater than 8 mLs? So if height puts you at less risk for getting a tidal volume greater than 8 mLs, but having your BMI puts you at greater risk for getting a tidal volume higher than 8 mLs. And pneumonia meant you had less risk of getting a tidal volume greater than 8 mLs. These are the clinical outcomes of subjects without ALI or ARDS at onset of ventilation based on tidal volume. So this column here looks at the patients that got the tidal volume less than 8 mLs, and these are the ones that 8 or greater. And really there's no difference between these two groups is how you would interpret that. None of the p-values are less than 0.05. So you could say mortality was the same, ventilator-free days was the same, the ICU length of stay was the same, and the hospital length of stay was the same. So these are initial ventilator settings and pressures among the 722 patients without ALI or ARDS at onset of mechanical ventilation. So these are this column here is the patients that never developed ARDS, and this is the column that developed ARDS after intubation. And really the one group that does stand out as significant is that the group that had developed post-intubation ALI or ARDS had higher peak airway pressures. But otherwise there was no real difference between the two groups. This table is the ventilator settings and parameters before and after development of ARDS, ALI in the 161 patients who developed ALI or ARDS after onset of mechanical ventilation. So these are the patients that developed ARDS after being intubated. So in this column here is what their tidal volumes were before they were intubated, before they developed ARDS, and then after they developed ARDS. So we can see that for certain, their tidal volumes got smaller. For predicted body weight, the second row is for actual body weight, and that also got smaller. This is tidal volume size, which was decreased, and this is PEEP, which increased. And here, there's no real difference between the plateau pressures. Even though the p-value is almost less than 0.05, it is still greater than 0.05, which means it could be doesn't meet the threshold. So this is hospital outcomes for the patients that never developed ARDS, and the patients that were intubated for ARDS, and the patients that developed ARDS after intubation. So what you can see is that the mortality group was highest in the patient population that developed ARDS post-intubation. The ventilator-free days, the post-intubation group had the fewest amount of ventilator-free days. They also had one of the longer ICU stays, and they also had the longer hospital stays. So here is a figure of intercenter variation in initial tidal volume settings among all intubated and mechanically ventilated patients. So on the x-axis here is the 22 centers, and on the other axis is tidal volume per predicted body weight. And these are box and whisker plots. Now what I've done is I've added two red lines in to kind of demonstrate what the ARDSNet target tidal volume per predicted body weight is. So the red lines were my addition just to kind of add a visual of what the target tidal volume is for ARDSNet.
So, Carl, this is Shauna again. If I could interrupt you one more time. This is a crazy little looking graph. Could you help us understand the point behind plotting data on this kind of a graph and what that can tell us?
Okay. Well, this tells us how each hospital sort of did in applying their tidal volumes. What a box and whisker plot means, and let's see if I can adjust my pointer. Okay. So this little black bar that's in each of the figures represents the median value for that particular center. So that would be the median tidal volume per predicted body weight amongst all mechanically ventilated patients. And then the box represents the interquartile range. So that would be the 25th through 75th quartiles or percentages of all the the tidal volume for all the mechanically ventilated patients. And then the whiskers represents, depending upon the authors, represents the range, so from lowest to highest. So how we could look at center 4 is that the median value for tidal volume came in about 9 mLs, but they had some outliers because if this is the centermost typical patient population and it's towards the bottom of the whisker plot, but the whisker goes all the way up here, then they had a couple of patients that were up here that had some pretty high tidal volumes. So this gives us kind of an idea of how each of these centers did practice, or how they set the tidal volumes for a typical patient, for all patients on mechanical ventilation. So these are the intercenter variation in tidal volume amongst mechanical ventilated patients that did not develop ARDS. So these were patients that had no lung injury or ARDS, and how they had, for all intents and purposes, I guess, relatively healthy lungs. So we can see that a lot of the box and whisker plots were above the ARDSNet target area. So a lot of the median values were above the target. And this figure is the intercenter variation in tidal volume amongst mechanically ventilated patients intubated for ARDS. And this is interesting because you can see centers 2, 3, and 4, they really took, they were very stringent in their application of the ARDSNet criteria. Center 1 really fell above it. and say for Center 12, they were better, but they also had some patients that fell out. Had some patients that had ARDS and ALI, but also received some very high tidal volumes, above 12 mLs. And this Center 11, I don't know how to explain them. And this is intercenter variation in tidal volume amongst mechanically ventilated patients with post-intubation ALI or ARDS. So this is these are the initial ventilator settings after the ALI or ARDS was identified. So there's a little bit closer trend towards keeping the median values within the ARSNet target range, but you can see that some of the centers still didn't manage to get within the target. So discussion. What do all these findings mean? So the application of low tidal volume is variable. As we can see by the figures of the box and whisker plots, clinicians are getting better about using low tidal volume, but we still have a lot of work to do. Sicker patients were more likely to receive low tidal volume ventilation. Ventilator settings and delivering a tidal volume less than 8 mLs predicted body weight is not associated with development of post-intubation ALI or ARDS, or on outcomes. Development of post-intubation ALI or ARDS was associated with more resource utilization. So if they developed ARDS after being intubated, they stayed in the hospital longer and consumed more resources. Subjects were more likely to receive low tidal volume if they were male, taller, and less obese. Shorter and heavier subjects tended to receive tidal volumes that were greater than 8 mLs per kilogram of predicted body weight. What are the limitations of this study? Analysis is based from the initial ventilator check. Anyone who's worked clinically can recognize that it's difficult to know what your predicted body weight right after you admit a patient. So sometimes the initial ventilator check may not be reflective of your actual strategy. The study also was underpowered to detect outcomes. Power refers to, in research, it refers to did you have enough subjects to actually detect a statistical significance. And the study didn't have enough subjects to detect those differences in outcomes. And the study was limited by its observational nature. If you look at the hierarchy of research, you have at one end that what they call low quality, be like case studies, case control trials, cohort studies. To the other end, which is high quality research, is the randomized controlled trial. The difference is the amount of control that the researchers are able to exert over the variables that they're looking to detect differences in. Observational trials, there's no protocol, there's no control over the variable. There was no control. The researchers had no control over the setting of the tidal volume. So since it was just observational nature, that's a limitation. Is there any additional work that's needed in this area? Yes, the point of research is always to generate more research. So questions we need to answer is why patients who develop ARDS post-intubation consume more resources. I think that's a very interesting topic. Prospective research for the role of ventilator settings on post-intubation ARDS is also something that should be explored. Whether or not when you begin ventilation, if you keep the tidal volume lower, is that going to prevent development of ARDS? There was an editorial that accompanied the journal. It was from Robert Dickinson, a physician. He pointed out that the main limitation of the study was its snapshot nature of the ventilator data, and that's a very good point because, in my hospital we actually have a protocol, and there's you start at 8 mLs, and there's a gradation to dropping them to 6 mLs, and then we sort of monitor from there. Hospitals have different protocols, and it's really hard to control because you're just shooting at 1 6-hour window for the initial ventilator settings, and that can bias the information. It was also difficult to ascertain if subjects received low tidal volume ventilation based only on ventilator data. Our hospital, we call something we call some lung protective ventilation LPV light because of the way the physicians manage it. And so you don't really know if they were trying to do a low tidal volume ventilation. It was only based on whether or not the tidal volume was set to deliver less than 8 mL. And the absolute difference between at intubation and post-intubation was small. So this is a good point. If we go back to look at the actual volumes between the two groups, we may find that the actual size of the volumes was less than 50 mL if you were looking at the median values. So even though when we know that they have ARDS, we drop the tidal volume, we still are, for most part, keeping the tidal volumes a lot smaller than we were when at least I started in the field. And also the message about lower tidal volume of RSNet seems to have gotten out. There are a lot of facilities, if we look at the go back to the box and whisker plots, when they knew the patients had ARDS, they did lower the tidal volume. So conclusions, there's improved but not ideal adherence to lower tidal volume ventilation. But the variation in ventilator management did not affect the outcomes. Post-intubation ARDS was associated with greater resource utilization. And what is the take-home message? You should still be an advocate for low tidal volume ventilation for your ARDS patient. And notice I didn't put ALI because it's now a defunct definition. And assure that tidal volume is calculated from predicted body weight and not actual body weight.
Thanks, Carl. This was a really great editor's pick. I have one more question from myself before I toss out the questions that our very active chat room has for us. Taking all of this, you know, the whole point in reading the journal and evaluating the data is to make an impact on our own patient outcomes. So, from a practical standpoint, how do you think respiratory therapists can impact patient outcomes based on the findings of the study?
I think the most important take-home message is if we look at if you were a larger patient, we seem to be very bad at knowing what the actual tidal volume is. We seem to be setting tidal volume a great deal on actual body weight and not on predicted body weight. And our practice here is each of the ICUs has measuring tape, and the ventilator settings are actually ordered according to milliliters of predicted body weight. So they don't order it in a raw volume, say 400 or 500 mLs, they order it in 6 or 8 mLs. So the therapists have a practice here of actually measuring the patient and calculating what the predicted body weight is and delivering the tidal volume according to predicted body weight. So I think the best practice really is to make sure that we actually measure our patients rather than try and guess based on actual body weight. So just as a quick poll, use the yes or no check mark up at the top. How many folks have a tape measure in their ICU to measure patients' height so that they can calculate this information? Wow. That's actually pretty. I'm kind of surprised. Surprised at the number of people who do have a measuring tape? Surprised that there is as many no's. Wow. Looks like almost 50-50 at this point. Yeah, it does. So here's a kind of a bad joke and a bit of trivia. What do you do for patients that are missing their lower legs? Can I answer the question, or is this a rhetoric? You want to provide the answer? Go ahead. As a matter of fact, a lot of people are typing into the chat room. You use their arm span. Yes, that's correct. From fingertip to fingertip, yeah. Fingertip to finger, that's, you use that in place of predicted body weight. It goes along with the, I used to say that I tell the residents when I give them a ventilator class, what do you do? Well, you add 2 feet. Ha ha ha. But no, really, you measure fingertip to fingertip.
So we had some really good questions. I've got what I think are some quick questions. One of the participants asked if predicted body weight is the same thing as ideal body weight based on height and gender. My initial response to that is yes. Is that what the authors were using as well?
Yeah, ideal body weight and predicted body weight are interchangeable terms.
And a technical question, someone asked, why is ALI a defunct definition?
Yeah, if you go back and read the Berlin the new definition, which is what they call the Berlin definition of ARDS, there was a release of a consensus conference information that redefined ARDS for purposes of research and clinical practice. And one of the things that they had done is they threw out the term acute lung injury, and now it's all ARDS, but we stratify ARDS into mild, moderate, or severe. So there's a new diagnostic and definition criteria for ARDS, and if you go to Google and search for the Berlin definition, you can find that criteria. But the term ALI, acute lung injury, I think is going to begin to go away in the research.
Thanks for the explanation. Back to the predicted body weight question, a follow-up question. Do we know if any of the centers in this study utilize a computer-generated predicted body weight based on input tidal volumes?
Based on input tidal volumes, or did the so for example, our institution, our tidal volume is per milliliters per kilogram is calculated by the computer. So if I input a tidal volume and I know the patient's height is also in the computer, when we input the tidal volume, what that is per milliliters predicted per kilogram pops up on the chart. So we can follow that. I don't know if that answers the question or not. And we were one of the centers, so I know that for us that happens.
So speaking of multi-centers, there was a question earlier about the multi-center study, and this I think is a more general question on when we use a multi-center study. Is there an assumption that everyone within that study, all of the centers included, deliver equivalent medical care, or do they follow a certain protocol for this study? Do you have any information on that?
So in general, because it's an observational study, there's no protocol that I'm aware of that they were following. So an observational study, so they were just looking at what people did. They made no intervention. They had no protocol. There was no direction to the caregivers to do this or do X or Y under certain situations. So I've gone back to the slide of intercenter variation in tidal volume amongst mechanical ventilator patients that did not develop ARDS. And one of the reasons I wanted to bring this slide up is if we look at Center 4, some of the tidal volumes are topping 20 mLs, and that's a fairly significant tidal volume, right? But it's not if that center is also a spinal cord injury unit where it may be routine to trach a patient, drop their cuff, and give them that much tidal volume, because a lot of it is escaping out their mouth. So there's a lot of practice variation between the centers, and that's why it's a limitation of an observational study. When you go to a formal research protocol and then it becomes a randomized controlled trial, that's the controlled part, then the value, because everyone's being managed the same, the value of the outcomes, the results of the research becomes that much stronger.
So that would be another good reason to look at that that box and whisker plot to identify that variation from center to center at kind of at a glance.
Right.
So did they, there were 22 centers in this study. Did the authors do any kind of analysis on whether there were regional differences in the care delivered and the tidal volumes used, or they didn't try to group the centers together through any kind of demographics?
No, it was just based on, they were all put into a single group, and it was just based on tidal volumes delivered. There was no northwest, southeast regional variation.
Great.
Which I think would also include other countries because it was international.
So if we were looking at this particular research study with regards to rigor and quality, we talked about how it's an observational study. If the study designers had instead created this study with a protocol and implemented that type of a study with all of these 22 centers, would that have a stronger, a higher quality product?
Yes. When you're moving along the scale, if you're looking at the levels of evidence, and there's a pyramid out there that looks at the levels of evidence-based medicine, as you go towards the top, the designs of the studies exert more control over the variables that they're trying to detect, like outcome. And so observational study, there is no control over the outcomes they're looking at. Then you have the prospective randomized trial, single center trial, that's stronger results than an observational trial. And then you do the randomized multi-center trial, and because when you're doing the multi-center trial, you're sort of eliminating regional variation and demographic variation, the results are then even stronger. And stronger means more believable, more applicable to clinical practice. That's why when you look at the original ARDSNet study, it was across several states. It was a very regimented fashion, and the protocol was very direct. This happened, you did X, and that's why the results were so believable.
Well, we're wrapping up last couple of minutes of our presentation. I'm kind of scrolling through the remainder of the questions, and it sounds like we sparked a lot of different conversations out there. I'm looking for one more that won't take us a long time to answer. So one question that one of our participants asked is, why were they tracking how much volume was used in relation to actual body weight versus, in addition to predicted body weight?
Well, I think what they were trying to get at was tidal volume being delivered by, were people measuring patients, or were they just looking at patients and deciding on what their tidal volumes were? Whenever I used to work in the ER and we'd get a trauma patient in, there's a lot of people around the bed and you can't really measure the patient, a lot going on. What you do is you tend to eyeball the patient and give them a tidal volume until later on you can be a little bit more smarter about it. And I think what they were getting at with what they found, if I can find that slide. So when you look at this here, the odds ratio, that body mass index here, if your body mass index gave you a higher risk of getting a tidal volume that was greater than larger than 8 mLs per kilogram of predicted body weight. That meant if you were a bigger person, they gave you a larger tidal volume. Now that's just data, but the interpretation of the data is, well, maybe what we're doing is we're not deciding tidal volume on what a person should be getting based on the size of their lungs. We're giving them tidal volume based on the size of their chest, and you know, that can really be skewed by having a large body habitus.
Thanks so much. This has been a really great session. I've really enjoyed being able to ask you a lot of questions about the statistical analysis, and I hope that that has helped our attendees as well. I've read the article in Respiratory Care Journal before I logged on, but I think I need to go back and read it again, maybe in a new light with all of this great information. So, Carl, thanks again for joining us today. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.